Hello, everyone. My name is Meena Ramchandani. I'm an infectious disease physician at the University of Washington in Seattle. This podcast is dedicated to an STI literature review for healthcare professionals who are interested in remaining up to date on the diagnosis, management, and prevention of STIs. I'd like to talk about the recent emergence of certain trichophyton subspecies in this episode. It's an important topic healthcare providers should be aware of, especially in the field of sexual health. Trichophyton cause dermatophytosis, which is also known as ringworm or tinea, and it's a superficial fungal infection that is easily treated with topical antifungal agents. There's a recent emergence of certain trichophyton subspecies, which are a public health concern and have been reported in several countries, including the US. The two types to remember for this episode are Trichophyton indontinae and Trichophyton mentagrophytes, genotype 7. Sexual transmission of both organisms has been described in case reports or in case series. These fungi can cause a severe, persistent dermatophytosis or pruritic skin rash in patients, often in the genital region if sexually transmitted. In the case of Trichophyton indontinae, antifungal resistance is a major concern, and treatment requires a longer course of therapy. A sexual history as well as a travel history can be important when evaluating patients with these infections. The first article to review was published in Mycosis in April 2025 by Dr. Descalzo and colleagues. It is titled Trichophyton mentagrophytes, genotype 7 and sexually transmitted tinea, an observational study in Spain. This group evaluated 14 cases of Trichophyton mentagrophytes genotype 7 between 2020 and 2025 at an STI clinic in Barcelona. They identified the organism based on DNA sequencing, which is the most common technique used for differentiating the Trichophyton subspecies. All patients were MSM, or men who have sex with men, and the median age was 37 years. 7 patients were persons with HIV on antiretroviral therapy, and they had a CD4 count that was greater than 500. 6 patients were on HIV PrEP or pre-exposure prophylaxis. 8 patients had concurrent STIs, for example, gonorrhea, syphilis, chlamydia, or mpox at the same time, and 4 patients reported recent travel within Europe. The rash mainly occurred in the groin or buttock and perineal regions. 2 patients had lesions around their beard or their mustache. For treatment strategies, 6 patients required multiple courses of treatment due to recurrence. 5 patients were treated successfully with oral terbinafine, and 7 with topical agents, either clotrimazole or terbinafine that was topically applied. Most patients required a longer course of therapy of 3 to 8 weeks, and all patients cleared the infection with a median time to cure of 49 days. Trichophyton mentagrophytes, genotype 7, has been reported in several countries as a cause of oral or genital dermatophytosis transmitted through sexual contact. Most reports indicate oral terbinafine for several weeks has been the treatment of choice for these infections. Now, this particular case series we just discussed by Dr. Descalzo and colleagues suggests topical terbinafine may be effective for certain patients, maybe those with less severe presentation. But if you're interested in learning more, including some pictures of the rash patients can present with, I suggest you also review an article published by Dr. Jabet and colleagues in the Journal of European Academy of Dermatology and Venereology that was published in February 2025, as well as one published by Dr. Zucker and colleagues in the Morbidity and Mortality Weekly Report in October 2024. The majority of patients in those articles received oral terbinafine to treat their infections. Now let's talk about Trichophyton indontinae, which is another emerging global pathogen with difficult-to-treat infections. Trichophyton indontinae is often resistant to the antifungal medication terbinafine, which is used to treat dermatophytosis, including Trichophyton mentagrophytes, genotype 7 that we just discussed. Case reports indicate other antifungals, such as ketoconazole or fluconazole, may also not work for these infections. The organism was initially described in South Asian or Middle Eastern countries, but now has been reported in 6 continents and in multiple U.S. states. I'd like to start out by reviewing an article published by Dr. Jabet and colleagues in Eurosurveillance in July of 2025 It is titled Autochthonous Transmission of Trichophyton indontineae Through Sexual Contact, France 2024. In this report, 4 cases of sexually transmitted dermatophytosis caused by Trichophyton indontineae in Paris are described. The age of these patients ranged from early 20s to late 60s. 2 patients were MSM with multiple sex partners, and the other 2 patients were female sex workers. 2 patients were living with HIV and were on antiretroviral therapy. 3 patients had not traveled outside of Europe in the last 6 to 12 months prior to the onset of lesions. And based on history, these 3 patients likely acquired the infection in France. The 4th patient likely acquired the infection in Portugal. 3 patients reported sex with men who were from South Asia in the previous months before the onset of their symptoms. And this group used mass spectrometry to identify Trichophyton indontineae and then confirm the diagnosis with molecular sequencing. They found 1 isolate that was resistant to terbinafine in their cohort of 4 cases. 2 patients received oral terbinafine, and the 3rd patient received topical ketoconazole. Clinical recovery was achieved in all 3 patients, and the last patient was lost to follow-up. This case series highlights Trichophyton indontineae infection acquired through sexual contact in Europe. Historically, this infection was associated with exposure in South Asia or in Middle East, but this case series suggests local transmission of this pathogen is occurring. While several of the isolates in this article were sensitive to terbinafine, isolates may be resistant to this medication. Typically, itraconazole at high doses and for long treatment duration is recommended for this infection, but relapse can occur. There are some interesting pictures from 14 patients with Trichophyton indontineae infection, published in February 2026 in the Journal of European Academy of Dermatology and Venereology by Dr. Rivera Lopez and colleagues, which I also encourage you to view if you're interested in learning more. The next article to review was published in Mycoses in August 2025 by Dr. Ribeiro dos Santos and colleagues. It is titled Global Emergence of Antifungal Resistant Dermatophytosis Caused by Trichophyton indontineae, a genomic investigation involving 14 countries. This group analyzed 347 Trichophyton indontineae isolates from 14 different countries and found 65% were resistant to terbinafine in vitro. Among the isolates which were phenotypically resistant to terbinafine, meaning they grew on media containing a certain amount of terbinafine or had a minimum inhibitory concentration greater than or equal to 0.5 micrograms per milliliter, using broth microdilution, 99% were genotypically resistant. They found that the isolates had mutations in the squalene epoxidase gene, which has been linked to terbinafine resistance. Just some background. Squalene epoxidase is an enzyme in the ergosterol biosynthesis pathway and is an antifungal target. The highest number of isolates they analyzed came from India, Germany, Bangladesh, and the United States. Using whole genome sequencing and a phylogenetic tree analysis based on single nucleotide polymorphisms, they did not find there was clustering by age, sex, or country. The Trichophyton indontineae isolates had less intraspecies genomic diversity compared with other Trichophyton groups, such as Trichophyton rubrum or interdigitale. This suggests Trichophyton indontineae is a recently emergent pathogen. They found 1 subcluster of terbinafine-resistant isolates that had a specific squalene epoxidase gene mutation at F397L, and it was widely dispersed among 10 countries. So this was a large multinational genomic investigation of Trichophyton indontineae using isolates from 14 countries. And this group found that the isolates were genetically close and did not cluster by country or origin. It suggests ongoing international transmission and possible recent emergence of this pathogen. They found that the majority of isolates, or 65%, were resistant to terbinafine. Next, I'd like to briefly review an article published in JAMA Dermatology in July of 2024 by Dr. Kaplan and colleagues. This article is titled Clinical Course Antifungal Susceptibility and Genomic Sequencing of Trichophyton indontineae. Trichophyton indontineae isolates from 11 patients in New York City were analyzed from 2022 to 2023. The median age of patients with this infection was 39 years, 6 patients were male and 5 were female. The majority of patients in this case series reported travel in Bangladesh before acquiring the infection, and the median time from tinea onset to diagnosis was about 10 months. All patients had received at least one topical antifungal medication without improvement when used as monotherapy, and many patients received more than one antifungal treatment. What they found in their case series is that 2 patients had resolution with oral fluconazole weekly for 4 to 12 weeks, but this treatment also failed in 2 other patients. So about 50% of patients in the cohort of 4 responded to treatment with oral fluconazole. 2 patients improved with griseofulvin that was given for 8 weeks, but another 3 did not improve with griseofulvin. What they found is that 3 patients had resolution with itraconazole, and another 2 patients improved at the last known follow-up. So a total of 5 patients had improvement or resolution of their infection with itraconazole. They found that itraconazole had to be given for at least 4 to 8 weeks. 1 patient was lost to follow-up, and another did stop itraconazole due to adverse effects. This case series highlights how difficult it can be to treat trichophyton and Dante infections, and patients might need to receive a long course of therapy. But they did find that the majority of patients had improvement with itraconazole. There is a nice review by Dr. Gold and Dr. Lockhart in Clinical Microbiology newsletter published in June of 2025, discussing the recently emerged dermatophytes of public health concern, which I encourage you to read if you'd like to learn more. To conclude, I'd like to summarize some key points from this session. Trichophyton mentagrophytes genotype 7 is causing sexually transmitted dermatophytosis in many countries, and patients present with a rash in the oral or genital region. Most reports indicate oral terbinafine given for several weeks can treat Trichophyton mentagrophytes genotype 7, although topical terbinafine might be effective in select cases with less severe presentation. Trichophyton indontinae, on the other hand, is an emerging pathogen that can also cause a severe persistent dermatophytosis, but the organism is often resistant to terbinafine. Sexual transmission has also been described. A long course of itraconazole has been used successfully for Trichophyton indontinae infections. This podcast is brought to you by the National STD Curriculum, the University of Washington STD Prevention Training Center, and is funded by the Centers for Disease Control and Prevention. Transcripts and references for this podcast series can be found on our website, the National STD Curriculum, at www.std.uw.edu. Thank you for listening and have a wonderful day.